There we go.
Okay. All right. So again, my name is Jeanette Locke. I am the director of the Greater Philadelphia Region and Multicultural Outreach at the Epilepsy Foundation, Eastern PA. I am also a mother of two who live with epilepsy. So just like you all, this is personal for me. So I just wanted to say thank you for having me, and let's just get started. All right. So I realize that not everybody is from this area, right? But we are the local affiliate in this region for the Epilepsy Foundation of America. Our mission is to overcome the challenges created by epilepsy through efforts including education, advocacy, research to accelerate ideas into therapies. If you are not connected to a local epilepsy foundation, please feel free to reach out and we can connect you with those that we, um, personally know. And if not, we will make some sort of connection if you do need to connect with your local foundation. Okay, so these are just some of the services for those who are in the area in Eastern Pennsylvania. But we do have services such as Project School Alert, which is where we go into the schools and we train not just the personnel, the teachers, but we also have specific training that is for age appropriate students. So we do have a training for like elementary school. We have a training for the upper grades that caters to, their grades. And if you don't know, that is something that is very necessary for children who live with epilepsy, because a lot of the times things happen and their peers don't know how to handle it, as well as, just knowing how to, welcome them into the fold, where there's no bullying and things like that. So Project School Alert is very important. If you need that resource, please reach out. First responders and law enforcement training, we do as well. Obviously, first responders and law enforcement are the people that, if there is an emergency with our kiddos, that is who we call. So we want to make sure that they're trained. So that is one of the priorities as well. We do transition services, which is, when your students are going from elementary and high school into adulthood or college setting. So those services are also very important. We do support groups. We do have 9 support groups at the foundation. Again, if you need to be connected with somebody locally, please let us know. We do advocacy, educational conferences and webinars. We do have a women's conference coming up in May, but throughout the year, we do have conferences that you can register for. All you have to do is go into our calendar, and everything that we have coming up for the month is always up. We do have information and referrals such as for doctors and community services. Camp Achieve. Camp Achieve is a week-long camp for children ages 8 to 17. And we do have medical staff on location the entire week so that the kiddos are safe. Obviously, when you have children who suffer from seizures, it's a concern. So a lot of the times children are not allowed to go to regular camps. So Camp Achieve allows them to be able to do the same things that every other child would do, but they have medical personnel on location in case anything does happen. Adult services such as PACES, CDS, MP, and Hopscotch, these are more geared for, how to live your best life while living with epilepsy. And then we have 2 retreats for the adults as well. The young adult retreat, which is ages 18 to 30, and then 30 and up would be the adult wellness weekend. And these are specifically geared toward, mental health, well-being, being able to connect with people that do live with epilepsy. The adult wellness weekend is not just for the people living with epilepsy, but it also opens the doors for the caregivers. So both the person living with epilepsy as well as the caregivers can come out to the adult wellness weekend. If you're interested in that as well, again, please reach out to us. All right, so why should we know seizure first aid? I mean, for you all, it's personal. It's something that you should know based on what your experience is with your children. But for regular people, it is also important to know seizure first aid. Anybody, anywhere can have a seizure. And if you look at the demographics on the screen, 1 in 10 people will have a seizure during their lifetime. And it does not mean that they have epilepsy or any other medical issue that is specific to seizures, but we will look at what could trigger those. 1 in 26 people will be diagnosed with epilepsy during their lifetime. And for that reason, we should know first aid so that you can help. All right, so these is just a few of the statistics for epilepsy. So approximately 65 million people in the entire globe are diagnosed with epilepsy. 3.4 million of those people live in the United States. 470,000 of those are children. Approximately 1 million older adults ages 55 and over will be diagnosed with epilepsy. Now, for your community, the estimated incidence rate for STX-BP1 is 1 in 30,000. So again, meaning that 3.3 to 3.8 million, 3.3 to 3.8 children per 100,000 will be diagnosed. Okay, so did you know? And if we were in a in-person setting, I would have you raise your hands, but we are not. So just for you all to kind of chew on. So did you know that most seizures are not medical emergencies? You'd be surprised how many people immediately call 911 the minute somebody's having a seizure, which we all know that it may not always be a medical emergency. Did you know that a person may not be aware that they're having a seizure? Did you know that seizures are not contagious? Younger populations, younger children do have that mindset that they believe that if they see somebody having a seizure, that they could actually have a seizure as well. Did you know that a person cannot swallow their tongue during a seizure? Obviously, that is for the tonic-clonic seizures. And again, that is a myth that people still believe to this day that someone can swallow their tongue. Epilepsy is a medical disease, so we will look at that as well. But at one point, epilepsy was considered a disorder, and now it is actually considered a medical disease. And finally, did you know that a person living with seizures can live full lives? Okay. All right, so let's learn some information here. So a seizure is considered to be a brief temporary disturbance in the electrical activity of our brains. A seizure can affect a person, their movements, their behavior, their actions, or even whether they are conscious or not. And just so that you all know, if you do have any questions, please just put them in the chat and we will get to them at the end of the presentation. All right, so some seizure causes here. So as we talked about, so high fever, infantile spasms is one of those things. Drug use or alcohol withdrawal, near drowning or lack of oxygen. These are just some of the causes that you see here on the screen. So cardiac events, metabolic disturbances, head trauma, brain tumor, infection or stroke, complications of diabetes or pregnancy, and an epilepsy diagnosis. So these are some of the causes why somebody might have a seizure. But when we're talking about epilepsy, epilepsy means that all of what we just read is really these seizures are not provoked by any of those things, except an epilepsy diagnosis. So epilepsy is also the same as a seizure disorder. Because of stigma, a lot of people don't like to share the fact that they have been diagnosed with epilepsy. So they'll just say, I have a seizure disorder, but it's the same thing. Okay, so causes of epilepsy. So 60% of people don't know why they have epilepsy, and only 40% do have some sort of understanding as to why they have epilepsy. So here on the screen, you will see a few of those causes of epilepsy. So things such as brain tumor, brain trauma, tumors, infections of the brain, such as meningitis, encephalitis, and measles, brain injury at birth, congenital malformations, or genetic causes. So the majority of people don't know why they have epilepsy. If you are the few, the 40%, then at least you have some sort of understanding as to why but the majority of people don't know why they are diagnosed with epilepsy or why it happened. Okay, so here are the seizure classifications. As you can see, the two brains on the right-hand side. So the generalized seizures are depicted in the first brain with all the different spots. And what that simply means is that the seizure is affecting the entire brain. They could be motor versus non-motor, which means they could either be tonic-clonics or they could be absence seizures, but they're affecting the entire brain. So again, they can look like convulsions, staring, muscle spasms, and falls. And then if we look at the focal seizure on the right brain, you can see there's only one dot, and that is because it is a focal seizure, and a focal seizure means that it's pretty much just affecting the one part of the brain. It could be aware versus impaired aware of a seizure. It could be motor and non-motor, but then the symptoms relate to whatever part of the brain is being affected. So if you look at the bottom brain, you see all the senses there. So whatever is being affected during the focal seizure, then it would manifest in the body. Okay, so new classifications. So obviously, we're doing research constantly. Things change with time. So what used to be a partial seizure is now a focal seizure. Generalized, again, simply meaning that it involves the entire brain. It's still the same. And then unknown onset, which means they don't know where it began. Levels of awareness here, what used to be a simple seizure is now an aware seizure. A complex seizure is now an impaired aware. Secondary generalization is now a focal to bilateral tonic-clonic. And again, epilepsy was considered a disorder and it is now considered a disease. All right, so here's the new classifications according to the ILAE in 2017. So the classifications of seizure types, this is just a basic version, obviously. So focal onsets, which were formerly known as partial onset. As you can see, they could be aware and impaired aware, and it can affect the motor, the non-motor, and then it can go from focal to bilateral tonic-clonic. Generalized can be both, again, motor and non-motor. Those categories would be the tonic-clonic and other motors, and then absence for the non-motor. And then, of course, the onset that is unknown, which is tonic-clonic or the absence. They just don't know where it's onset. And unclassified, meaning that they don't have enough information to place where the category would be. So some of the seizure types associated with STX-BP1, you can see on the screen, and I'm sure you all are pretty familiar with neonatal seizures. These are seizures that occur in the first month of life. Infantile spasms, which are brief involuntary muscle contractions, often occurring in clusters. Tonic seizures characterized by stiffening of the muscles, clonic seizures involving the rhythmic jerking or twitching movements, focal impaired aware seizures, seizures where the individual, they stop whatever they're doing, their behavior, and then they become unaware. Myoclonic seizures, which are sudden brief jerks or twitches, and we're going to talk about all of this just a little bit more. Atonic seizures, which is the sudden loss of muscle tone. Absence seizures, which are brief periods of staring with altered consciousness. Generalized tonic-clonic seizures, which are convulsive seizures with stiffening and jerking. And then the focal seizures that affect one part of the brain. Okay, so these are just some possible seizure triggers, and it's important to know these because if you know the triggers, oftentimes you can avoid the seizure. So missed or late medication. For those of you who don't know, some people are very sensitive to the times that they take their meds, so they have to take them at the same time every day, or they might have a seizure. Emotional stress, which is, can be whether they're extremely excited type of stress, happy stress, I'm sorry, or just regular stress can be a trigger. Sleep deprivation. Some people who live with epilepsy need to sleep at least 10 hours in order to avoid having a seizure. Hormonal changes. There are some people that who have epilepsy that only have seizures around their menstrual cycle. Alcohol or recreational drugs can be triggers. Drug interactions, you have to make sure that you can't just go to the store and get anything over the counter. You have to make sure that it doesn't interact with whatever medications you're currently on. Missed meals or specific foods or drinks, nutritional deficiencies, specific stimuli such as flashing lights or patterns. I recently went to go do a training in school, and they had a child there who would be triggered by certain patterns, so that the parent sent a letter to the teacher every year letting her know that, if she could share with the other parents in the classroom not to wear patterns, but just, regular clothing that had no patterns at all because it would trigger her daughter. Hyperventilation, other stimuli, and then sudden loud noises. These are all triggers. All right, so routine first aid, care, and comfort. So most seizures are non-medical emergencies. If somebody is diagnosed with epilepsy, sometimes you just have breakthrough seizures. So they're not all going to be emergencies when they have a seizure. All seizures should be timed and documented. This is for obviously the parent if say this is a school setting, and even at home, if you want to make sure that you know the time frames of how long the seizure lasted and to document it so that when you go to the next neuro appointment, or if you need to give that information right away, that you have it and you know what the seizure looked like. Making sure, one of the things that I always suggest is to keep a seizure diary, a notebook that is specific for the seizures, making sure that you're timing it, that you're documenting everything that it looked like. We also do have a document for specifically for that, for a seizure observation. So if you do need that, please let us know. Basic first aid has common elements. Obviously, it's going to depend on whether the person is having a certain type of seizure. So if there's no change in consciousness, if they're altered in their awareness, or if they're fully unconscious, we're going to do first aid differently. Okay, so this is going to be the first seizure type. This is what is considered the tonic-clonic or convulsive seizure. So I love this, this illustration because I think it depicts very well the stages of the seizure. So as you can see, the aura stage, a person might be confused. They might have a hallucination. They might become dizzy. Their emotions are distorted, or they may have some sort of numbness, among other things. The aura stage is something that I think if somebody does actually have an aura and they can vocalize or make sure that they get to a safe space, if they know that the seizure is about to happen, it's a beautiful thing. If they don't have an aura, unfortunately, the seizure happens and they're not prepared. So anyway, after that, it moves into the tonic stage. The tonic stage is when the body stiffens. They may have some sort of epileptic cry, some sort of sound. They may have incontinence, and then that's when their back becomes arched. And then it moves into the clonic stage, as you can see, the jerky movements, the frothy saliva, and the blinking eyes. And then it moves into the postictal stage, which we'll talk about a little bit more, but that is when the seizure is over, the shaking and the convulsing is over. They're going to be tired. They might not be able to stand up. They will be sleeping. So this is just some of the rest of the information here. So these seizures usually last about 1 to 3 minutes. Sometimes they will have some sort of shallow breathing. Their skin, nails, and lips may turn blue because they weren't getting the proper oxygen. And when they come out of the seizure, they're going to be confused and have a headache. So first aid for this type of seizure. We want to stay calm. If you've never seen this type of seizure, it can be scary, especially if it's your first time seeing it. Staying calm is essential in order to be able to render first aid. Protect the person, your child, from any harmful objects that may be around. If they're on the floor, or if they're on the bed, you want to make sure that they're not, hitting any furniture. Observe again and time the events. That is extremely important. We want to make sure that we know exactly how long the seizure lasted. Ensure that the airway is unobstructed, cushion and protect the head, turn the person to one side, remain with the person until they're fully conscious, and then follow the person's seizure action plan. And this goes with anybody, whether it's, in this community, it would be your child or, but in any setting, you want to make sure that if the person is known to have epilepsy, that you check to see if they have a seizure action plan so that you're following what instructions have been given. The two do nots in this type of seizure: do not put anything in their mouth and do not restrain. So just recently, I received a phone call from a mother who her son was a teenager. She allowed him to travel and he ended up getting stuck in a layover in North Carolina. He had a seizure and somebody put something in his mouth and broke all his teeth. So of course she was upset. And that, I think, is something that there's still a huge lack of understanding and knowledge when it comes to not putting something in somebody's mouth when they're having a seizure. And then the other do not is do not restrain. Obviously, we want to make sure that the person's body is able to do what it needs to do, and holding them down, it can hurt their muscles as well as you getting hurt in the process of holding the person down. Okay, so this is just an example of that tonic-clonic seizure.
The classic thing that people tend to think of when they're thinking of seizures, and that's the tonic-clonic seizure, or what we used to call the grand mal. It can also be, on the other side of the coin, what we used to call petit mal, where all we're seeing is an absence of a person. They just go blank for a moment, stare off, maybe a little bit of movement. And so we have the huge range from the biggest, the strongest, the most worrisome for most people, the grand mal or the tonic-clonic, all the way down to a little bit of movement or simply staring.
Okay, so again, we're going to talk about the postictal time. After this type of seizure, the person will be drowsy and confused. They probably will be sore or have a headache. Give the person some time. It could take up to 15 to 20 minutes, and then ask them if they're able to speak. If they're old enough to speak and have a conversation, you want to make sure that you're asking them open-ended questions such as, what is your name and where are you? We don't want to give yes or no questions. We want to make sure that they are able to respond and understand what you're asking. A person will need rest after this. And if you are out and about with your child and they have this type of seizure, just make sure you have some sort of blanket handy just in case something does happen and they have incontinence. Okay, so now we're going into the absence seizure, generalized again, meaning that it is affecting the entire brain. And that what that looks like is a pause in activity. We're going to actually watch a video that shows us what that would look like. They would have a brief lapse of awareness. They could look like they're chewing or blinking. These last about 1 to 10 seconds, and sometimes they're confused with daydreaming, inattentiveness, ADD or ADHD.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
There's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Absence seizures can be mistaken for daydreaming. One of the hallmarks of absence is that the seizures happen many times in a day. Sometimes they're so fleeting, they're easy to miss. This boy is having frequent but very brief episodes. You can see his eyes flutter up. He's out of touch. Then he becomes fully aware again.
Okay. So generalized onset for myoclonic seizures, again, generalized meaning that it's affecting the entire brain. That might look like a sudden, brief, shock-like muscle jerk. It will involve the whole or parts of the body. Can cause a person to spill something if they're holding something, or they can fall off of a chair unexpectedly. Their consciousness is not impaired, so they are aware, and it may occur as one seizure or in clusters. Again, generalized, the entire brain. Atonic seizures is a sudden loss of muscle tone. It may cause an individual to collapse or fall to the ground. Usually not fully aware during this event. Typically, these last about 15 seconds or less. These often start in childhood and can last into adulthood. And most often, children with these types of seizures will wear a helmet. So first aid for all three of these, so the absence, the myoclonic, and the atonic seizures. Timing the event again, this is very important. We want to make sure that we know how long the seizure is lasting. Observe and record, again, very important for your neuro team. Make sure that the person returns to baseline, which means that they will come back out of it and that they can have a conversation with you. They can respond to your questions. Check for any injury. Obviously, this would be more so for the myoclonic and atonic seizures. And then repeat any information that may have been missed. So that for the absence and the atonic, obviously they might not been, well, with the absence, you're definitely missing information because they're not aware. So we want to make sure that if there's any information that they're missing, especially in school, that they are caught up so that they don't fall behind. Okay, so seizure types and recurrence. So as you can see, we're going to go into the focal seizures now. And then the focal seizures are just affecting the one part of the brain. And as you can see, most seizures are focal seizures. Only 30% are generalized, meaning the entire brain. And then there's only 10% where the onset is unknown. Okay, so I'm just going to leave this up for a few seconds so you can all look at the different parts of the brain that can be affected during a focal seizure. If you just look around, let's say on the left side, you see that the Broca's area can affect the speech. And then on the, say the occipital lobe, it could be the vision and perception. So wherever the focal seizure is happening, that's what part of the brain would be affected, and it would manifest in the body in that way. So focal onset aware. So consciousness is not impaired with these. It could look like involuntary movements, such as isolated twitching of their arms, their face, or their legs. Sensory symptoms could look like tingling, weakness, sounds, smells, tastes, and visual distortions. Psychic symptoms are deja vu, hallucinations, fear, anxiety, or a feeling that they can't explain. Duration of these are less than a minute, and it will be or can be confused with acting out, mystical experience, mental illness, or psychosomatic illness. So first aid for these, when there's no change in the consciousness, stay calm. Again, timing the seizure is important. Make sure that you're reassuring the person that he or she is safe. Explain to others if necessary. This obviously would happen if somebody's asking questions in the midst of this type of seizure, making sure that we protect the privacy of the person. So focal onset impaired aware. These seizures are altered in awareness. They have blank stare and dazed look, automatism such as picking at their clothes, nonsensical speech, clumsy or disoriented movements, or aimless walking. They can look like they're picking things up. These can last 1 to 3 minutes, often followed by tiredness, headache, or nausea, and sometimes can be confused with drunkenness or drug abuse and aggressive behavior. And here's just 2 examples here of a focal impaired aware.
Another common form of seizure that is not nearly as obvious is the complex partial seizure. Because only a small part of the brain is affected, a person may still be able to perform gross motor skills like walking or sitting upright, yet be totally unaware of his or her actions. They may stare, mumble, repeat phrases, blink excessively, smack their lips, or pick at their clothing. However, they will be totally unresponsive to instructions because their consciousness is severely impaired.
Let's say somebody were speaking to me. I might remember none of it, a little part of it, or it might be all jumbled together.
Kevin, can you hear me? Can you hear me?
It can look like something else. It can look like a student's not paying attention. It may look like a student is, using substances they're not supposed to be using.
I think it's important that a teacher not assume that the student is simply not paying attention or is, daydreaming, that they understand it is possible to have these more subtle forms of a seizure, where the mind sort of just checks out for a few minutes.
Their consciousness is impaired. It's not lost. But they're clearly not processing language and they're not processing your intention. So that what you want to do is take harm out of their way, close the door. They will take the path of least resistance.
But a perception of being threatened will lead to somebody pushing away, hitting, fending off what, at least momentarily, as a reaction, is thought of a threatening move.
So that I think the most that you would want to do is guide. You don't want to restrict them. You don't want to force them to sit down. That is the last thing you want to do.
A complex partial seizure can last from 1 to 5 minutes. When it's over, the person may be tired or may recover immediately. Emergency medical services do not need to be called if a person who is diagnosed with epilepsy experiences a complex partial seizure, unless they're not fully recovered within 30 minutes.
Okay. So first aid for this type of seizure, timing the seizure again, speaking softly and calmly. As you saw, they're not aware of what is happening, so you want to make sure that you're calm and not screaming. Guide them away from anything that they can hurt themselves with, such as tables, chairs, and doors. We want to allow them to wander, but in a contained area. If you see the video, every time I watch it, it stresses me because he's in the middle of the street. But we want to make sure that, obviously we want to keep them in a contained situation. If it lasts beyond 5 minutes of what is routine for that person, obviously everybody alters so that everybody's seizures don't look the same. But if another seizure happens, or if it's more than 5 minutes or more than what is routine for that person, we want to make sure that we follow emergency protocol. Do not restrain the person. As you saw in the video, if you're grabbing somebody in that state, they're going to be combative simply because it's like a fight or flight reflex. And then do not shout or expect verbal instructions to be obeyed because they're impaired in their awareness. So when is a seizure an emergency? So any first-time seizure is an emergency. Any seizure lasting more than 5 minutes, repeated seizures without regaining consciousness, most seizures than usual, or a change in type. So if your child is having a specific type of seizures, this is what they're used to, and then they exhibit a different change in type, then we want to make sure that we call for help. If a person has diabetes or is pregnant, if a seizure occurs in water, that's always an emergency. Obviously, if a person is injured in the midst of a seizure, we're going to call for emergency rescue. And then if a parent requests, obviously you all are the parents, but if you are going to put it in their seizure action plan, you want to make sure that you're clear about what the instructions are. So postictal psychosis, this is something that affects 6 to 10% of people with epilepsy. It occurs post-seizure, so after a seizure, and it resembles a psychotic episode, but it is not a standalone psychiatric disorder, so meaning that it only happens after a seizure. It could involve delusions, hallucination, and mood disturbances. Varied duration ranging from hours to days. So it could happen hours after the seizure or days after the seizure. This is usually treated with a low dose of antipsychotic medications. Obviously, this is not everybody, but some people do experience this, and you want to make sure that the neurologist or the epileptologist is aware, and that they're the ones that make that decision. So SUDEP, sudden unexpected death in epilepsy. I think this is something that is very important to know about, that is not often spoken about. So sudden unexpected death is something that happens in an otherwise healthy person that has epilepsy. There's no identifiable cause when an autopsy is done. It is the leading cause of death in those with uncontrolled seizures. Approximately 1 in 1,000 people with epilepsy die from SUDEP annually. The person would often be discovered deceased in the bed without any observable convulsive seizure. So meaning that it's not in the midst of. Over a third of cases involve witness seizures or signs of a recent seizure. Commonly discovered lying face down. Cause of death varies between cases. Theories include irregular heart rhythm triggered by the seizure. And then other research suggests death results from breathing difficulties post seizures. So obviously there's still a lot of research being done around SUDEP, so things are changing all the time, but this is something that I think every parent needs to know about. These are just some of the things that you can do to minimize the risk of SUDEP. And that would be to take the medications as prescribed, regular medical checkups, open communication with your doctors, seizure diary, healthy lifestyle, avoiding triggers, safety measures, and then wearing a medical bracelet. Okay, so treatment options for people with epilepsy: anti-epileptic drugs, surgery, ketogenic diet, VNS, or other brain stimulation devices, which we will go over. These are just some of the common medications for epilepsy. 50% of people that are newly diagnosed can become seizure-free on medications. 75% of those with epilepsy have seizures that are well controlled by medication. So these are just some of the ones that are out at this point that are being used. So common side effects, I like to spend a little time on this because I think it's important to know that there are so many side effects, and that there are side effects that happen in the process of getting the dose as it should be for the person. Obviously, everybody's brain is different, so there's different medications, there's different cocktails, if you will, so different medications that are used together that might work for one person but not another. So on the left-hand side, you see the dose-related side effects, trying to get the doses as they should, and they can experience the side effects on the left. So diplopia, blurry vision, dizziness and lightheadedness, sedation, slowed thinking, feeling drunk, coordination problems, and unsteady walking. And then you get to the drug-related side effects, the cognitive problems, fatigue, weight gain or loss, cosmetic things such as acne or excessive hairiness or hair loss, hyperactivity or slowed movements, personality changes, mood changes, and depression. These are all side effects of the medications. So I think it's important to know this because, we only see the outside portion of it. We know our children, and then they're not just having seizures, but they're also going through all of these things that are, happening because of the medications. Okay, so these are just some of the rescue meds that are prescribed for people living with epilepsy. I think at this point, a lot of people are using the nasal spray, but those that are up on the screen are still viable options that people use. So the diazepam rectal gel, the lorazepam, the clonazepam wafer, and then, the 2 nasal sprays that I want to say most people are on at this point, and then the Versed. All right, so surgery for seizures, obviously this is something that is considered, after all medications that can be used have been unsuccessful. So it takes a while, because obviously you're going to try to, mix and match and see what does work. When it doesn't work, the medications, this is when surgery would be considered. Making sure that knowing exactly what the seizures and where they're focused, and to see if they can remove that portion of the brain without causing any further loss to the child or person. This is some of the testing that would be done in order to consider the seizure surgery. So some of the procedures are considered for focal resection, temporal lobectomy, legionectomy, hemispherectomy, and corpus callosotomy. Obviously, they would have to test with an EEG, MRI, the SPECT scan, PET scan, and they also do a neuropsychological test. So this is not something that, is a long-term stay in the hospital. It's pretty quick. Usually it takes a few months to recover. So they would be missing school if they were considered for surgery. All right, so the ketogenic diet, it was introduced in the 1920s. The treatment was for children who were not controlled with medications. What it does is it produces a state of ketosis using a diet high in fat and low in protein and carbohydrates. Most of the time it is used in children. It is effective for all seizure types, so not one specific, but all seizure types. It would require 2 to 3 days of fasting, and then it is followed by a very strict diet. Compliance sometimes is problematic. And then the side effects can include renal calculi, weight loss, cardiomyopathy, and blood abnormalities. Okay, and then we're going to get into the devices. So this is the VNS. As you can see, it almost looks like a pacemaker. It is, supposed to lessen or prevent seizures from happening. And what happens is they implant the device in the left chest area, and then the electrode is attached, as you can see in the illustration there. It's attached to the generator device. And then the electrode is attached or wound around the vagus nerve in the neck. The device is programmed to deliver pulses or stimulation at regular intervals. And the person does not have to do anything for this device to work. No MRI while the device is on. Now, if a person is having a seizure, they can use the magnet as you see there. They can swipe the magnet to send the extra burst of stimulation to the brain. And then for some people, it does help stop the seizure or decrease the severity of the seizure or how long it lasts. Usually people who have a VNS, they wear this magnet either on their wrist or their belt. Then the magnet can be used as needed as long as it's at least 1 minute between swipes. And then this is the RNS. The RNS is a neural stimulator that is placed under the scalp, as you see in the illustration there. And it is connected to 2 electrodes that are placed inside the brain. The device continuously monitors brain activity, so it's almost like an EEG, a continuous EEG in their brain. So when a seizure is detected, the device delivers a small amount of electrical current. It is used for patients with seizures originating from 1 or 2 regions of the brain, and you can't use an MRI with this one. And then this is the other one, the deep brain stimulator, the DBS. This one has electrodes that are surgically implanted in certain areas of the brain. The electrodes provide stimulation directly to the brain areas that are involved where the seizures are happening. It might be more appropriate for patients whose epilepsy is more widely distributed. And they can have an MRI with this, obviously done safely with a medical professional. So seizure observation record, this is something that we can share with you if you would like that. This is something that is helpful in making sure that you can keep track of what the seizure looks like, what was happening in the moment, what was happening right before. This way you can pinpoint the triggers for your child. So if you do want that, please let us know. Seizure action planning. So seizure action plan is something that is pretty much a team effort between the caregiver, the neurologist or epileptologist. And, if you are sending this to school, everybody would have a part in the seizure action planning. It allows the school or anyone, say if you're sending your child to camp or anything outside of your home, you will want to have a seizure action plan. It provides the information on what the seizures look like, what type of first aid, you would want for your child, and then when and what will constitute an emergency for your child. Again, you would give this to whatever organizations you're, having your child go to, whether it's school, whether it's dance class, or, whatever it is that you have your child in activity wise. Okay, so now we're going to touch on, excuse me, some seizure safety, because, most of the time, obviously, you're at home. So most seizures, seizure-related accidents do happen inside the home, and creating a safe home environment is important. The risk that a person with epilepsy will be injured during a seizure at home can be greatly reduced by taking some simple safety precautions, and that's what we're going to look at now. So these are some things that, you can, just kind of look at when you're looking around your house, just to see what is safe and what is not. So in the living space, avoiding any glass tables, and then using shatterproof glass for mirrors. Installing wall-to-wall carpet or soft flooring when possible to cushion potential falls. Try to avoid clutter in the room, making sure that you allow for space in case your child does have a seizure and falls. Securing televisions, computers, or any other things that could potentially fall off of tables in the event of a seizure. Use chairs with arms to prevent falling if a child is sitting and has a seizure. Close fire screens in fireplaces when fire is burning. Make sure that irons, curling irons, have automatic shut off to avoid burns. Pad furniture with sharp corners or purchase furniture with rounded corners. Safety in the kitchen, so using a microwave instead of a stove. This obviously, your children are small, but at some point they might want to make food as they get older. Using pre-sliced food, so you don't have to use knives. Not using glass, but instead using plastic containers, plates, and drinking cups. Using cups with lids just in case they do have a seizure and you don't want, them to get burnt. If the person needs to move any hot food, sliding it on the counter, or putting it on a cart rather than taking it physically from one room to another. Using rubber gloves when handling knives or washing dishes and glassware in the sink. Make sure that someone is home if possible while cooking. Safety in the bathroom, so making sure that there's showers instead of baths, installing rails or grab bars, or even a shower chair. And use of occupied sign instead of locking the door, just in case there is a seizure. Keep water levels in tub low. Hanging doors that open outward instead of inward, in case somebody does have a seizure. A person with epilepsy should not use electrical appliances near water. Well, I don't think any of us should, but and then use carpet in the bathroom if you can. Safety during sleep. This is obviously very important. Avoiding possible suffocation with anti-suffocation pillows. Sleep on a low bed or mattress on the floor. Limit the amount of pillows on the bed. Remove anything that is sharp or dangerous that is around your bed. So any glass lamps, items, candles, anything that can break by the bed, we don't want to have that there. Pad sharp corners again, or side tables of your bedroom furniture. Use a monitoring device if possible. I'm not sure if you all are aware of the SAMI camera, but that's a good one. And then any seizure detection wearables, which there are some out in the market now. And then have a way to call for help near the bed. General safety, this is literally, for older people, but we're going to go over it. So avoiding being at home by yourself if you have uncontrolled seizures. For tonic-clonic seizures, use of seizure detection devices are recommended. A seizure detection dog. Recruit a friend if you're going to exercise. Going to do outdoor activities, making sure you have your cell phone with GPS locator. Wearing a medical alert bracelet. Telling someone where you're going if you have to go anywhere alone. If you're prone or your child is prone to overheating, carrying a cooling rack. Making sure that your household tools have automatic shut off, obviously never swimming alone, wearing a helmet if you're prone to falling, list your emergency contacts in your health app, in your phone, wallet, or purse. Carry your seizure action plan is very important, and making sure you have your rescue meds. And if possible, have a hospital plan. Okay. So these are, just some of the things that we do help with. So again, if you need help connecting to a foundation near you, or if you are nearby and would like to connect with us, please let us know. And so now we're going to go to our questions, if there are any.
Thank you so much, Jeanette. This was really, really great. I think all of the information was definitely necessary for our community. So this is really awesome. We did have one question, but you kind of addressed it, but maybe you want to talk about it a little bit more. And that was about seizure action plans. So could you share a little bit more about maybe what a seizure action plan would look like, and maybe a scenario where it might be used? And I can give an example myself of how we've used ours, but I'd love to hear from you first.
So the seizure action plan is one of the most important tools a parent can have. Simply because, when we walk away from our children, whether we take them to school, to a family friend's house, let's say, can you keep my kid for the day? And you should always have some sort of paperwork. And the seizure action plan is just that. It states what the seizure looks like. This type of seizure may last this long. If your kid has more than one type of seizure, well, this seizure looks like this, and it could take this long. And then you want to make sure that obviously this is something that you talk through with your neuro, your epileptologist, even their primary physician, so that everybody's on the same page. If you're sending the seizure action plan to school, making sure that, okay, this is when this becomes an emergency, and this is exactly what I want done for my child when I'm not there. It's very important, because if you don't have a seizure action plan, then most of the time people don't know what to do, especially if they've never encountered, I didn't know what a seizure was before my kid had a seizure. I had no idea. And when my son had his first seizure, I mean, he was completely, in the postictal state, and we thought he was joking. We're like, what are you doing? Get up, get up. If people don't know what a seizure looks like, or what, to do after a seizure, it almost, you're putting your child at risk, because people just don't know how to handle it. So it is one of the most important tools that we can possibly have as a parent, if you're going to have your child outside of your vision.
So I'll just talk. So for STX-BP1, this just came up in a comment that I received, but it's very true with our kids, is that we'll see that the seizures will change over time. So they might start by having maybe focal seizures, and then and maybe they present as, an absent seizure. And then they'll change over time, and they might become generalized, and they might become tonic, they might become tonic-clonic, So we see this progression of seizures in our kids, and I think it's important for the seizure action plan to address that, right? So that so you might need to change that action plan based on the type of seizure they're having. And you might find that maybe the rescue medication that you had for one type of seizure, maybe you need to change it to something else for another type of seizure. I know that, not only from experience, but just from knowledge from our community, that these are the things that we see that should be addressed in a seizure action plan. What type of medication, when to give it, what type of seizures are they having, how long do they typically last? But these are things that are often changing in our kids as they get older, and the seizures change. So just something to be aware of. So that was a great comment from somebody. I know that for my son, at school, everybody is required to carry a red bag. He has a red bag, and every single person that is with him needs to have that red bag, and they need to have it with him at all times. So wherever he goes, that's where that red bag goes. And in the red bag, we carry his emergency medication, and he does have the nasal spray. And he has a VNS. So his VNS, he has a magnet that is also kept in the red bag. We don't have him take care of it, take care of the magnet because, as most of our families know, our kids do have some level of developmental, disability, and so the cognitive issues don't allow them to be able to take care of that on their own. So I think, having it in the red bag along with his emergency medication wherever he goes has been super important. But then it states in that seizure action plan when to use those medications, what to do, what is the order. We use the magnet first. That's what it states in the seizure action plan. We're going to try that magnet first. And I think it might even say to try the magnet twice before we give the emergency medication. And so, I'm trying to remember what it says exactly, but I believe that's what it says. Try that magnet once, give it like 30 seconds. If the seizure doesn't stop, try it again. And then if it doesn't stop with a second swipe, then we would give him the emergency medication. I will also say that the VNS has been amazing for our family. It was one of the most difficult decisions to make. But the surgery is not that bad. I mean, obviously, my son, it might be different than another child, but from what I have heard from other parents, they felt the same way, that it wasn't that, it's an outpatient surgery for most patients, and it has been a game changer. It really has been a game changer. And just for parents who are watching this, I think as a parent, knowing that I can help my son while he's having a seizure is so empowering. And it just makes me feel really good to know that I can help him, because the magnet does stop his seizures. And just one more thing on the VNS. He used to have drop seizures, atonic seizures, and he would start off with a tonic and his body would stiffen. And then at the very end of the seizure, he would just drop. Since having the VNS, he has never dropped. And that's because that VNS stops his seizure before it gets to the drop. So that has been incredibly life-changing for us.
It's amazing. That's
Yeah.
wonderful. And you know what? Parents need to hear that. Sometimes it's so scary to make such a huge decision.
It is.
So that's amazing. That's awesome.
Yeah. And I think a lot of us put it off because we're scared of the surgery. But if they're going to have those benefits and you as a parent can have more control over the seizures, I mean, it's been worth it for us. So, anyways, just wanted to bring that up. Okay, so we have a couple other comments. So let me read this. Okay, so we have somebody that's been very newly diagnosed that's on the webinar today. So I'm sorry that you have received the diagnosis, but at the same time, I am also glad that you have received the diagnosis. Many of us waited years to get the diagnosis, and it looks like you guys got the diagnosis after 3 months, which is, to be honest, very, very incredible. And now you can have that knowledge and be able to help your child. So it says, any resources that we can review. I'm going to get you connected. So as I said at the beginning of the webinar, I am our community engagement director. I'm going to get you connected with other parents. So I will send you an email. Okay. It's Brittany. I will send you an email, Brittany. Okay. And then how old is my son? My son is 19 years old. So we've been doing this for quite a long time. But I will tell you that getting diagnosed when he was younger was very difficult. So we actually did not have a diagnosis until he was 10 years old. So, but now kids are getting diagnosed so much sooner. And I think it's great because we're able to help them so much sooner, and you're able to, get the knowledge and the information that you need to help them. Okay, any other questions? Please put them in the comments or in the chat. Anything else? I think I just wanted to mention a couple other things. one thing was that there are some special pillows out there that I've been made aware of, that we talked about suit up. Suit up is a really difficult thing to talk about. And we unfortunately have had some suit up related deaths in our community. It is rare, but it does happen. And I just wanted to say that I know that it has been brought to our attention that there are some pillows out there so that if a person is sleeping and they have a seizure, that they should be able to breathe better using these different pillows. That was brought up to us previously. And then the monitoring devices, like you said, Jeanette. There's some really great monitoring devices, and I think getting in contact with what are the organizations? Is it the Charlie Foundations for Ketogenic Diet? The ketogenic diet, by the way, is something to consider as well, and talk with your neurologist about if your child is having uncontrolled seizures. It has helped some of our families incredibly. But Danny did. The Danny Did Foundation, that's the one I'm thinking of. The Danny Did Foundation can help you to decide maybe what type of monitoring device would be best for your family, depending on the types of seizures that your child is having. But also just having a camera in their room at night is helpful so that you can monitor and see what's going on during the nighttime, because your neurologist is probably going to ask you, are they having seizures at night? So you need to, and I don't want to tell you to sleep with your child. You have enough already on your plate. And but I think that if you had that monitoring device, that hopefully you'd be able to capture enough information. So let's see. Okay, I do have another question that just came up, and this has happened to me as well. Eating while you're having a seizure while eating. I know. That's a difficult one. And I just had somebody else share with me that that happened with their child. That has also happened with us.
Same.
And same with you.
Unfortunately, my son ended up he aspirated food and he ended up with a pneumonia to the point where we almost lost him. So it's, I mean, we can't predict when the seizure is going to happen.
I know. I
So,
know.
you know, the only suggestion I would say is always be with them when they're eating.
That's true. Yeah.
That's all we can do. I mean, we really don't have a control over, knowing and just being able to predict that. So, yeah.
I will say that I recently, and I know a lot of several families in our community were talking about this, but there's a new device for choking. You put it over the mouth and it somehow like suctions out the food. So that might be something to look into. Um, you know, I mean, just to be prepared and, like you said, just be watching your child. I think for our kids, especially when they're younger and maybe all the time, we have to monitor how much food we give them. Um, our our kiddos oftentimes are known for stuffing their mouths with food. And so I think being able to monitor how much food you give your child at a time can be helpful just to prevent choking in general, but especially if they were to have a seizure while they're eating. But that is a hard one. And I agree. I think probably many of us who have a child who has seizures might have experienced this. We've experienced it a few times, and we've luckily been able to work through it without aspirating or having to call paramedics, although we were very close one time, but we've been able to work through it. So I think it's just another reason to really try to get the seizures under control. However, whether it's with medication, a VNS, through ketogenic diet, I just think controlling those seizures, obviously the best that you can do will lessen that likelihood. Any other questions or any other comments? How old was your son when he had surgery? Okay, so it was during COVID, which was not fun, that we actually did the surgery. I think it was, I think we waited until the spring of 2021 because they had kind of put a stop on a lot of the surgeries. So it was March of 2021. So it hasn't been that long ago, what, 4 years ago now. So he was 15. So he was 15 years old. Um, and that I will say, and I think Jeanette, you might agree with this, and we see this in our community, but it's also other communities. A lot of times that kids with epilepsy, the seizures can get worse during puberty. That's definitely one of those triggers and times when seizures, and it's not just STX-BP1, it's like in general. So just something to be aware of. I think that that was definitely going on with him, and his seizures had gotten worse. To be honest, I'm glad he was home with me. I'm glad he was home with me during COVID, and I got to witness, what was going on with him, because that was definitely a difficult time for his seizures. And that's when we made those difficult decisions. But like I said, looking back, it probably was the best decision we made for the VNS. I don't think that people usually jump right into that, and I don't think doctors do either. Obviously, they're going to try to control it with medications or maybe ketogenic diet first. So, anything else? I I think I just had one last thing that I thought of, unless anybody else has a question. Okay, I don't see any other questions or comments. All right, so the last thing that I was just going to mention is that I think a lot of people get confused with absence and focal. I see that a lot. And I loved how you explained it today and how you showed the images. And so maybe just talk about what those two differences are just really quick, because I see a lot of parents who get confused and they'll say it's a focal seizure when they really mean it's an absent seizure, right?
So absence, obviously, it's again affecting the entire brain. And it's, it could be 1 to 10 seconds where they are, absent, if you will. And the focal seizures can resemble that, but it just simply means the focal seizure is only affecting one part of the brain. And obviously, we're not in the brain, so we don't know. And this is where the distinction of really knowing what type of seizures your child has and how they manifest. Because they can change, and as you just stated, Melissa, like they change as their age changes. And so a focal seizure could be, it could be affecting, say, their vision. They might be seeing something, but then another down the line, the focal seizure could be affecting their speech or something else. So absence means, they're absent for a couple of seconds, and they can resemble what we would say is a focal seizure, because those could be aware and impaired aware. So I think that's where people get a little, they don't really understand. And I think when you are first diagnosed, or you're first learning the terminology and things like that, you just, you say what you think. But yeah, so the focal seizures are one part of the brain. The absence seizures are generalized, meaning that it affects the entire brain. Did that make it a little bit clearer?
Yeah, absolutely. Yeah. And then, like I said, I loved the images that you showed, and that a focal seizure, it focuses on one part of the brain, right? It's focused on one part of the brain. And so a focal seizure doesn't necessarily mean that they're having, a vision type of thing.
Right. And I
Right.
think that's exactly what it is. They say focal because they think it's, like they're losing focus. And I think that's, where people get confused.
Yep, absolutely. Okay, I did have one other question come through. It's kind of a little bit off topic. I think it's our newly diagnosed family just asked about our event that we're having this summer. So we have an STX-BP1 summit every summer. This year it's in Colorado. We're very excited to be in Colorado this year. A little bit closer for me. I'm in California, so not having to travel as far. Last year we had the summit in Philadelphia. This year is in Colorado. And so this is where families come together to meet each other. We'll have different social opportunities for families, for our kiddos, also for siblings, grandparents. But then we also have presentations, and the presentations are on the research that's happening with STX-BP1, including clinical care for STX-BP1 patients, and anything new that's happening with STX-BP1, including any upcoming clinical trials for medications or therapies that are in the pipeline, which is very exciting. We have some very exciting things happening, and so we're looking forward to our event this summer. If you have any other questions, please send me an email. I'm going to make it easy on everybody. If you have any questions, send an email to info@stxbp1disorders.org. So again, that's info@stxbp1disorders.org. I get those emails as well as a couple other people on the foundation, but I will be sure to answer any questions that you have. Okay. All right. Well, I want to thank you again, Jeanette. This has been wonderful. I'm so glad we were able to record this today. We can share this with the rest of the families that weren't able to make it. And this has just been really, really great information for our community and for our families. So thank you again. I appreciate it. Thank you. All right, everyone. It was wonderful having you join us today, and I will go ahead and end the webinar and just look for the recording to share. Bye, everyone.